we begin our examination with the cervical spine. All our examinations begin with inspection. On the inspection of the neck, you're looking for any atrophy of the musculature, which would denote possible nerve injury. You're looking for any spinal abnormalities, such as an exaggerated lordosis or kyphosis. And you're also looking for any skin changes indicative of rash or erythema on there. After we do inspection, we will do purposeful palpation. On the neck, we're specifically palpating for spinous process tenderness, which would be indicative of an abnormality that may need radiographic evaluation. And then you're looking for any muscle tenderness, any trigger points specifically in the trapezius muscles or the paraspinous muscles. After we do inspection and palpation, we'll do range of motion. So they'll break. Okay. Range of motion of the neck would be full flexion. You ask the patient to touch their chin to their chest. Then you'll do full extension where they fully bring their head back, then go back to neutral. And then we'll do rotation where you do neck or chin to one shoulder, chin to the other shoulder. Then we'll do lateral flexion where you'll do ear to each shoulder. You're looking for any asymmetry from side to side or any reproduction of the pain. We've now completed our inspection, our palpation, and we've done our range of motion. Next, we will do our neurovascular testing. We'll start with strength. Realize that the nerve roots innervate multiple muscles, so it's hard to isolate one, but we'll kind of do it in a systematic process. So first, we'll test our deltoid musculature. We ask the patient to resist us on both sides. Next, we'll test our biceps, ask the patient to resist you. Then we will do our wrist extensors. Don't let me break you. Then we'll do our wrist flexors. Then we will do our tricep strength. Then we will do our finger flexors. And then we will do our finger abduction. And so we've done C5, C6, C7, C8, and T1 for our strength testing. Now we will go ahead and test for sensation. And for that, we will test for the C5 area on the outside of the shoulder. C6 will be tested on the web space. A nice little mnemonic for C6 is if you have the patient make an OK sign, that looks like a 6. And so you can remember that that's the sensation for C6. C7 is in the middle portion of the finger. C8 is on the outside. And then T1 is on the medial aspect. And so one way to do that is to take a monofilament and say, do you feel me touching you here? Do you feel that?
Yes.
Do you feel this?
Yes.
Do you feel this?
Yes.
Do you feel this?
Yes.
And do you feel this?
Yes.
So we've done C5, C6, C7, C8, and we've done T1. Next, we'll do our reflexes. For our reflexes, we have three. We have C5, which is the bicep reflex. Then we have C6, which is the brachioradialis. And then we have C7, which is the triceps. And that would complete your neurovascular assessment. So next we will do our special test for cervical radiculopathy. Our first test is called the Sperling test. And the Sperling test, you can ask the patient to try to look back into their back pocket. And so that would be a combination of side bend and extension. And you're seeing if they have any characteristic reproduction of a cervical radicular symptom, meaning symptoms along that dermatome and myotome. If they have symptoms, that would be a positive Sperling. If they had a history of that, but this does not exacerbate that, you can provide some compression that would compress those nerve roots and see if they have reproduction of their symptoms. If they do have reproductive of their symptoms with the Sperling test, then the next test you would do would be the shoulder abduction test, where you ask them to put the palm of their hand on top of their head, and you ask them if their symptoms improve with doing that. If they do, that would be more indicative that they have symptomatology of a cervical radiculopathy. And that would complete our special test. Good?